Hey everybody, Jennifer here, ready to do the Science of Resuscitation video recap. Remember that these days we've learned that high quality CPR is king. Let me get a little king crown there. High quality CPR is king. In fact, high quality CPR is what achieves ROSC. The components of high quality CPR are compressing at a rate of 100 to 120 beats per minute. And the American Heart Association recommends that we use a metronome. I have a metronome on my phone. I'll talk to you about that in a different video. But 100 to 120 beats per minute. Remember that 120 beats per minute and greater is associated with reduced coronary perfusion pressure because the heart doesn't have enough time to fill and enough time to empty. It stays empty longer. And below 100, the concern is that the circulation isn't fast enough to get gas exchange to occur. The next part is compressing 2 inches. And it's really hard to imagine 2 inches as you're compressing on the patient's chest. We don't pull out a ruler. We don't measure how deep we're going. I've heard at different intervals it explained as being 1/3 the depth of the chest. But according to the American Heart Association, 2 inches is the key number there to remember, the key landmark. I can tell you that if you check for a femoral pulse during compressions, you should feel one generated. Average cardiac arrest, not someone who is in a hypotensive state beforehand, just in general. So my recommendation is that you get a Sharpie marker and during CPR, palpate a femoral pulse. When you find it, put an X on it. And that way you know exactly where to go to check again to see if compressions are good. And if your hand is on the femoral pulse at the moment that compressions are stopped, you know if the pulse continues or whether it stops as well. So great way to reduce time frame. And the next thing you want to remember, the next measurement, so to speak, is going to be allowing for complete recoil. So remember that we don't want to bounce up and down off the chest. We don't want to lose our landmark, but you do have to get your body weight off of the chest with each and every compression. Compressing the heart squeezes the blood out of the heart. Lifting up allows the blood to be vacuum sucked back in to the heart. So squeeze, vacuum, squeeze, vacuum. And if you don't allow for complete recoil, then the blood doesn't come back into the heart with that vacuum suction. So remember to allow for complete recoil. Let me clear a little bit of space here. The next component of high quality CPR is remembering to switch rescuers at the 2-minute mark. So we used to try and muscle through and do a lot more CPR, but all the studies have shown that the longer we do compressions, the less effective we are. In order to maximize our compression perfusion, coronary perfusion pressure, we really need to minimize interruptions, compress for 2 minutes, and do a regular switch. Keep the rescuers fresh. Keep them on the chest, but keep them fresh. The American Heart Association has also begun recommending that we use feedback devices, and I think this is really wonderful. If you don't have a feedback device or you don't know what they are, please keep an eye out as you watch the videos. You'll see chest compressions being performed with a small yellow box in the center of the chest, and that yellow box serves as a metronome and gives feedback on the depth of compression and the speed of compressions. If you don't have any sort of device yourself, they're fully worth looking into, and several of the monitor defibrillators made today will incorporate either a metronome or some sort of compression feedback device that would sit on the center of the chest. And finally, sort of to sum it all up, the American Heart Association recommends that we monitor coronary perfusion pressure, CPP, coronary perfusion pressure. Now here's the catch. We really can't monitor this in the average cardiac arrest. You need to have placed arterial lines or Swan-Ganz catheters or other stuff that simply not possible in the average cardiac arrest. So what we can do instead to measure perfusion is we can monitor end-tidal CO2. And that is, of course, inline monitoring of an endotracheal tube, or it can be used on an iGel or a King LT airway. So once there's an definitive or semi-definitive airway in place, we can monitor end-tidal CO2. During CPR compressions, an end-tidal CO2 less than 10 millimeters of mercury is associated with no likely response. They are not likely to return to have ROSC. But if you can get their end-tidal greater than 10 and actually greater than 20, it indicates that there's a viability to your patient. And the way to get greater than 20 is to remember to switch rescuers at the 2-minute mark. So that's really important. Keep your rescuers fresh. If you have CPR underway and the end-tidal drops below 10 millimeters of mercury, you want to consider swapping out your rescuer. You certainly want to confirm landmark, depth, speed, and so on. But in order to obtain ROSC, you need it to be greater than 20. That's when you're most likely to get it. So remember, high-quality CPR is king. It is the most likely thing to bring about ROSC, and the American Heart Association summarizes this as push hard and push fast. Let's talk about chest compression fraction. Chest compression fraction is best described as the percentage of time with compressions underway. So we would love to believe that we do compressions 100% of the time that we are with the patient. But sadly, that's not true. In fact, a lot of studies have shown that chest compression fractions are less than 60% of the time. That means little over half of the time that you're with the patient, compressions are actually going on. So not a great number. Let's get a number up here on the board that we can work with. The American Heart Association says that ideally chest compression fraction should be 80% or greater. 80% or greater of the time that you're with the patient. Remember that you have to interrupt for pulse checks. You have to interrupt for intubation. You have to interrupt for defibrillation. If you're pre-hospital, you have to interrupt to move the patient up and down stairs or from behind the toilet, wherever we find the patient. So it's understandable that you're not doing compressions 100% of the time, but to be doing compressions less than half the time is of great concern. So we want to minimize interruptions. We want to minimize interruptions. But the question is, how do we minimize interruptions? Well, first of all, we can start by working within our team and pre-planning the roles and responsibilities of the team. This is going to come up in the team dynamics lecture a little bit more, so please keep an eye out for that. We can also pre-plan for the medications that we're going to give. We can acknowledge the limitations of where we're doing CPR and plan a move that would involve interrupting CPR just one time to get the patient into an optimal setting or circumstance, position, in order to do compressions. I think one of the biggest time wasters that I've noticed on arrests, both in and out of the hospital, is in the switching of the CPR providers. There should be no delay and there should be no confusion. One person exits to the right or the left and the other person enters from the opposite side. You can coordinate this very easily to minimize that interruption. And finally, we spend a lot of time evaluating whether there is or is not a pulse. Well, I mentioned earlier taking a Sharpie marker and marking the femoral pulse. If you know where the pulse is going to be, you don't have to poke around for a long time determining that it's not there. So anything you can do to minimize interruptions. Let's move on and talk about excessive ventilation for a few moments. Remember that excessive ventilation increases gastric insufflation, and that's something that we've known about for a while. And of course, if we overinflate the gastric area, then we get vomiting. So we've always been on the watch for that. But another thing that it does, I mentioned earlier, is that it increases intrathoracic pressure. It creates back pressure on the heart, so the heart can't expand and can't fill properly. Increased ventilation or excessive ventilation decreases venous return. It decreases cardiac output. As a result, it decreases ROSC. So let's avoid excessive ventilation at all times. Not just for the vomiting, just at all times. So instead of excessive ventilations, let's talk about effective ventilations. Effective ventilations are between 500 and 600 milliliters per ventilation. The average bag valve mask, the adult size bag valve mask, can be between 1,600 and 2,000 milliliters. That's a lot of ventilation. We never want to squeeze the bag dry. And in this case, 500 to 600 milliliters, well, that's about half of the bag. So watch out for the excessive ventilation, and those ventilations should be given 30 compressions to 2 breaths is the ratio if the patient doesn't have an intubation or definitive or semi-definitive airway in. Once there is a definitive or semi-definitive airway, you want to give 1 breath every 6 seconds, which is about 10 per minute. I think I got that right. There you go. So your numbers for effective ventilations, 500 to 600 milliliters, doing a ratio of 30 compressions, 2 ventilations if they don't have an airway. And once there is an intubation or a King LT or an iGel in place, then we're going to go ahead and do 1 breath every 6 seconds for a total of about 10 per minute. One final component of the Science of Resuscitation video was discussing the rapid response team or the medical emergency team, RRT/MET. There's going to be a separate video to watch for that, and I highly recommend that you watch it. The content is a little bit too much to talk about here, and I'd rather find a better way than me using my scribbles to get the point across. So there you go. Science of Resuscitation recap.